This is a biopsy from someone who has suspected metastatic carcinoma. We can see small bowel here with the muscularis propria, also muscularis propria here. So a metastasis has stuck together the peritoneal surfaces. There's a slightly different pattern of infiltration here and here, but let's go and look for some key features. Okay, this is a micropapillary pattern. In a micropapillary pattern, the cells secrete not into a lumen, but into the space around them, giving rise to this clear space around the cells. Sometimes in the micropapillary pattern, you may see little blood vessels in the papillae, but mostly you don't. So micropapillary patterns are commonly associated with high-grade serous carcinoma of the ovary, serous carcinoma of the endometrium, and micropapillary tumours from other organs, particularly the breast. So which one is this? Well, it's in a good place for it to be a serous carcinoma of the fallopian tube and ovarian origin. It's got some probably calcified bits here. Seroma bodies are not an overwhelming feature. Over here we've got a slightly different pattern. We do have some seroma bodies here. And here we can almost imagine it replicating the fallopian tube. But the best way to tell where this has come from is to do some immunohistochemistry. So the immunohistochemistry you'll probably want to ask for is a p53, because all high-grade serous carcinomas of tubo-ovarian origin and uterine origin are p53 mutated, just about. WT1 will be helpful in telling the difference between uterine and tubo-ovarian origin, because WT1 is usually negative in endometrial carcinomas. In addition, PAX8 will tell you whether or not it is very likely to be a female gynecologic origin. You might want to add something like a GATA3 to rule out breast. So, in other words, this is most likely a high-grade serous carcinoma of tubo-ovarian origin. Of course, we would correlate with the CA125. We can do a marker on this, but often it's already been done as serology and with the radiology. Thank you.